Well, thanks very much, Ron. That was a great presentation and background to start on with what I'm going to be talking about today, which is the really the assessment and diagnosis of transgender youth and adolescents. I'm hoping at this point you can all see the slides that I have on my screen. So a little bit of background about myself. I'm a child and adolescent psychiatrist, also general adult psychiatrist, and I have a special interest in transgender youth, also adults. And back in 2012, I started a clinic at Red Cross Hospital in Cape Town, helping young people and their parents with transgender issues. And back in 2012, I maybe saw one new case or one new young person every 6 months. Now, sometimes I have 3 referrals a week. So this is an area that really is expanding enormously. And I think all of us at some point or other in mental health are going to come across this population of people and need to have skills. Essentially, my assessment was a bit different. I have worked in the UK for a number of years and trained there before coming back to South Africa. And the Tavistock is the main clinic there. And they kind of do 10 sessions before anyone gets referred to for hormones, which is a bit overwhelming for me because I was going to be working pro bono at Red Cross, and I work out in the wilds of the Boerland mainly, so I didn't have time to do 10 sessions. But luckily, partly because I was forced to, I came to a model of helping these young people and assessing them, which I think is far more appropriate to our population, but frankly, every population, which is really quite a significant amount of time, 2 or 3 hours on the first assessment. And I find particularly in this issue, young people come with burning needs and parents want answers. And it's not really helpful to draw the whole process out over a whole number of weeks. It's much more helpful to have one assessment. And what I've got on this slide here is really what I do in that first assessment, which is to first take a history, an actual assessment. And this part is very important. Sometimes I can tell within 2 minutes that this child really is transgender, but it's not helpful to just be jumping to management and conclusions. First of all, it's really important to have both parents in the room. I'm a bit of a dragon, and not just for transgender, I insist that fathers come along. In South Africa, often mothers are just expected to deal with mental health care and healthcare for that matter. And actually, particularly in the area of transgender, the assessment is really all about getting parents to understand what's going on. And if you just see the mother is going to have to go home and explain all of this to the father, and you're potentially setting up a split right from the start. And invariably, you'll have to do the whole assessment again with dad, because a lot of the assessment is about feedback and psychoeducation. So, as I say, the sort of program I've sort of follow each time is to first do an assessment with both parents in the room, taking a history, usually from the parents first. If they are a teenager, I do give them the option of being on their own first, but most of the young people I see opt for having the parents in the room, and they give me their history. And as part of that history, I'm also doing psychoeducation. And in fact, all the facts that I'm going to be giving you this morning, I give to every single parent I see. I do an enormous amount of psychoeducation, because the truth is most people don't understand this area that well. And in order to make good decisions, the parents need to understand all the facts. But having seen the parents, I also see the child on their own. And then I do the second phase, which is essentially feeding back to the parents, which is parents alone. I tell the child, I'm teenagers as well, and they know by that stage that I'm on their side in terms of advocating for them. But then I see the parents alone, because the parents often need to ask questions that they're afraid of asking in front of their children in the room, because they might upset their children. But those are the best questions, all about, you know, didn't they catch this because it's a trend, and all of those sort of things, which I can quite easily answer, but it's much easier for the parents to voice those questions without the child. And then the third phase, which is in many ways the most important, but all three are important for the parents, but really management recommendations. And again, there, I see the parents on their own for most of that, but bring the child in on the end, hopefully at a point where the parents are supporting something helpful for the child to help them feed back to the child where they are on all these issues. Very important to remember in an assessment, us as clinicians should not be making decisions. The paternalistic line of telling parents what to do for their children is completely outdated, I would argue, on most aspects. Even though I might have very strong feelings about what is needed for their child, I always stress to the family that they are going to make their own decisions with their child. Now, one's taking a bit of a risk there, because of course, some people are quite conservative. But what I find is, if you present all the facts and make it applicable to the family, invariably, most parents do indeed love their children and want the best for their children. And they do come to a point by the end of the first long assessment where they are wanting to support their children, be it a social transition or hormonal interventions or whatever it is. But I think for when I've read about parents who've been upset by evaluations, it's often been that, you know, it's 5 minutes and the clinician is supporting the child with a transition, and the parents don't feel listened to, they haven't had their questions properly answered, and they're sort of feeling railroaded and told, well, your child's going to kill themselves if you don't do this, which I don't think is a helpful way to, and a respectful way to approach parents. So I think it's very important to set up an evaluation in a way that's going to be respectful and really make the information relevant to the particular parents. So even when I'm referred a transgender child as such, I will still say to the parents, which is true, I'm going to do my own objective evaluation. Well, before we get to terms, no, I'll go on to terms now. So when I talk about psychoeducation, right from the start, the first history I take from the parents is a gender history, which is what's going to be helpful to work out if the young person is transgender. And I explained to them that when I was young, you were either male or female, and that was kind of the end of the story. But we know today scientifically that that is naive and doesn't really carry the full range of the spectrum of what we know, as I say, scientifically. But I say that this picture of the genderbread person, sometimes I show them the picture, or I just say there are 4 axes of gender that most of us can relate to. And I start with biological sex, the body on the outside. And I explain that while most people are on the poles, either a female body outside or a male body outside, some people have bits of both body or intersex. And I ask them, you know, I'm assuming your child is female on the outside or male on the outside, and they say yes. It's also a helpful thing to start with the axis that's not controversial, that, you know, people are kind of relieved that they can actually answer a question and know the answer. Then I move on to gender expression, and I take a history from the parents of how their child was grown up. And gender expression with children is things like what clothes did they like to wear? Did they like to play with same-sex or opposite-sex kids? Um, and did they like typical boys' toys or girls' toys? At the same time, with the child in the room, importantly, while I do say to parents, they can tell me stuff on their own if they want to, I do encourage them to initially talk with the child in the room. I am giving little signals to the child throughout, and these kids pick them up even if they look as though they're not listening to us. And I say things like, this doesn't inform your gender identity, but it's just helpful for me to build up a picture of who you are in terms of gender expression. I have, by the way, missed out one very important thing, which is when the three come into the room, I do say to the child right at the start, what name and pronouns do you like me to call you? Now that right away signals to the child that I am respectful of them and liberal, basically, and going to be okay. To 90% of them, once I've said that, they know already. And even if they're not ready to give me their honest answers in front of their parents, they already know that information and they tell me which name and pronouns. But even if it's their dead name or their birth name, they know what I'm going to be like. So then the parents tell me about the history of gender expression. Then I move on to sexual orientation, which for young children isn't necessarily relevant. But I also make it light and say, has your child discussed these issues? I don't push people, but sexual orientation can be controversial. But for many, they have already spoken about that to their parents. And also with all of these different axes, it's very important to ask the parents, just what do you know? And sometimes they turn to their child for answers. And I say, no, I want to know just what you know at the moment. It doesn't matter if you get it wrong. And I remind the young person that I'm going to send their parents out of the room and they can tell me where their parents got it all wrong. I make a bit of a joke about it, but so everybody knows it's okay if they're not getting the right information. And then lastly, I explain that there's this fourth axis. Most parents know that there's something going on about gender identity, and that's why they're coming to see me. But some don't really understand what it is. And I explain that gender identity is independent of these other three axes, but is really about who people feel they are on the inside. Even though they might have a male or female body on the outside, it doesn't mean that you identify as being that. And I also explain that this is a very strange concept because most of us are born with a body and we feel okay with that body. So it's a very foreign concept to think that some people might feel their body isn't in line with their gender identity. We've never thought about it, is the case for most people. It's important to do a lot of empathy with the parents, not to alienate them and make them feel that you're part of some militant activist group that's going to tell them what to do with their child, but actually somebody who understands them. So alliance building and making it important that you can, stressing that you can understand them, all of these things are important. So essentially, in taking the history, I've educated them on what transgender and cisgender is. Cisgender is if your body is in line with your gender identity, and some of the basic terms which are useful and non-pathologizing, like gender diverse. What's also really important then is when I see the individual patient, I don't make any assumptions. As I say, right at the beginning, I ask the young person what name and pronoun they like me to use. But then when I see them on their own, I ask them, exactly the same things in terms of the four axes. But if they say they're transgender, I'll ask them what that means to them. And particularly with the spectrum, I will say, well, if this is male and this is female, where do they fit in on the spectrum? Are they 100% male or female, or are they 80% female, or exactly in the middle? Very important to not assume you know what young people are meaning, but always give them a spectrum. And if they can, ask percentages. Most young people feel they 100% the opposite sex when I see them, but increasingly they're people that are gender non-binary, or even if they are transgender, will say they feel they maybe 90% the opposite gender in their gender identity from their bodies. In general, women are better than men at understanding gender identity, and perhaps cisgendered women might feel that they are 90% female, but a bit male. Men, on the whole, are completely oblivious to gender identity if they're cisgendered, and why would they want to be female with so many advantages in being male? But anyway, that's for another discussion. But it's important to just ask questions and not be intimidated. In the section that I see the young people on their own, what is very useful there and what makes it possible to not to have to do 10 sessions with young people is that young people that are gender diverse are abnormally advanced developmentally in understanding their gender identity. Gender identity develops between the ages of 2 and 3 years old. Sexual orientation only develops between the ages of 7 and 8 years old. So gender identity is a very early on thing that's going on in development. And for these young people, every day they're getting messages from their environment that something is wrong. They told boys stand here and girls stand there, and it doesn't feel right for them, particularly when they get to school and gender and binary kind of allotment becomes more and more of a thing. So they think about gender every single day usually. And as a result, if they do have access to the internet, when they they start to do searches, and in a history, I always ask young people, when did you first feel something was different? When did you first find out about the word transgender? And it often is age 7, they went on the internet and they typed in boy who feels he's a girl, and up popped the word transgender, and then a whole lot of information that, of course, they read in private, and they are many experts. Many of these kids know just as much as I do in terms of gender, and I've learned pretty much everything I know from the young people I've seen over the years. Fortunately, it's been backed up by the evidence-based information, so it's good information. But yes, they're abnormally advanced. And many adults and professionals don't understand this. In the Tavistock ruling, I think that one of the most problematic things recently in the UK was that they didn't understand that these kids are from a very young age able to make very good informed decisions about their gender. Essentially, just mentioning a couple of terms in front of their parents will be enough information for them to understand that I'm going to be supportive. While I also work with a team, the neurodiversity team, that specializes in Asperger's and autism. And I realized when I started this clinic that there seemed to be a much higher proportion of young people who were also on the autistic spectrum. And initially, I thought it was me making a mistake and overdiagnosing. But since I found out that internationally, this is exactly the same profile that's seen in other parts of the world. Having said that, kids on the autistic spectrum do present usually rather differently, as in only after puberty starts do they become more aware of their gender identity. And some of them haven't worked out things when I see them for the first time, and many of them present as gender non-binary and later go on to feel, from having been maybe 50% female, they go on to feeling that actually they're 100% male later. So they do present a little bit differently. So I'm going to now talk about some of the other things I also talk about in the assessment, the incidence of transgender, because this is also an area that many parents are confused about. It used to be thought to be 1 in 10,000 for trans girls and 1 in 30,000 for trans boys. We now believe it's about 1 in 200. All over the world, the figures are heading for that. And as I say, I'm seeing that trend here in the Western Cape with a huge amount more referrals. And we think the reason for this is the internet and media, with gender diverse people coming out at a much younger age all over the world. And I do hasten to add that that doesn't mean the parents must rush home and switch off the Wi-Fi. The internet doesn't make them transgender. It just helps them in understanding that they're not the only ones who feel that way and what they can do to help themselves, which is incredibly important because their prognosis is hugely improved if they get the right interventions when they're still young. As I think I've mentioned before, most of them, particularly the neurotypical, as in young people without autism or Asperger's, feel they're 100% the opposite sex, but there is also a spectrum, including genderqueer, somewhere in the middle. Very important, after I fed back to the parents, that I think their child is transgender, which invariably it is, because in this day and age, I haven't seen a single child that's pretended to be transgender to freak their parents out. Maybe they do it occasionally around being gay or lesbian a bit, but it's been a very hard journey for every single child I've seen to eventually say to somebody that they feel they're transgender. But then in giving the feedback or the of what we're going to be doing about all of this, I talk about some facts. And everything I say, by the way, right from the beginning, Ron mentioned the WPATH guidelines. I make it very clear to the parents that everything I'm telling them is based on the WPATH guidelines, which it is. And when I say something else, I will tell them if it's just my opinion. And I think this is crucial in this area. It is very controversial for some people. So when parents bring their children to me, they don't want to think that they are just getting my opinion based on the last 3 or 30 patients I've seen. They want to know that everything I tell them is based on science and the best outcomes for their child, which it very much is if you base your facts on the WPATH guidelines, which is what we should be doing for the whole of medicine, but particularly in transgender health. It's really important that we make this clear to the parents and act in that way. So I then tell them that, first of all, mental health people used to blame parents for the children being transgender. We used to think along the same lines. We blamed the parents of schizophrenics, that mothers were overly close and fathers distant. And then once that had been disproved, it moved on to gay and lesbian kids and blaming the parents. And then this relative backwater, because most professionals weren't very aware of what was going on with transgender young people. And this is why there's so much teaching to be done today, because most clinicians, even in mental health and endocrine, don't really understand the area that well. And so I explained to them that the early research was all done into what parents did wrong, the first 20 years of research. And after 20 years, they couldn't show a single cause in parenting that caused young people to be gender diverse. They'd look at parents who had 5 daughters, and the youngest one felt she was transgender or he was transgender. And they saw, did they treat the child differently? They couldn't show a single thing. So ironically, while that research is very pathologizing, it's incredibly helpful to mention that, to reassure parents that it was not their fault, because a lot of parents come with terrible guilt that somehow they were either too permissive or they neglected their child. And even if they know they didn't do that, their parents or the school teacher or somebody else might have that view. And then I explained to them that we know almost certainly today that there is a biological component. And I explained that with the case of congenital adrenal hyperplasia, where where women carrying female babies in utero, XX chromosomes, who have a much higher level of testosterone, give birth to girls, but when those girls grow up, sorry, can you just switch off your microphones? I'm hearing interference. Basically, a much higher proportion of those babies feel they're actually men, even though they're female otherwise. And that was the first time doctors started to think maybe this is not the parents just screwing up the kids, maybe there's something biological. And the short story, I can talk more later, is that today people are fascinated in the difference between male and female, not just for transgender reasons. And there are a lot of research done on people's brains. And they look at things like size of the different parts of the brain, blood flow, and connectivities. And while most of the brain is the same, certain parts are bigger or smaller depending on whether you're male or female. But there is a bell curve. It's not one or the other. There's a sort of a spectrum, but there is a typical female pattern and a typical male pattern. And guess what? If you take a group of transgender women, their brain pattern will follow the typical cisgendered female. Now that's huge, because what that means is when a young person or an adult comes to one and says, I'm deeply unhappy with my body, I felt it's always been wrong, probably their brain is the opposite sex. And the best science is showing us that. And we need to listen to them and not just send them for some sort of therapy because they're confused. We need to take it seriously. Kind of sad that we've had to wait for scans before many people will take them seriously, but it is a good scientific fact to be able to tell some parents and many clinicians to help them accept young people. In terms of the diagnosis, the DSM and the ICD are the two big diagnoses sort of categories. And both of them, the changes more recently have been away from pathologization. So in DSM-5, there's a new chapter of sex and gender disorders outside where they used to be with paraphilias and dysfunction. So it's less about having a problem. And the term that is used now is gender dysphoria rather than gender identity disorder. So you can see the language is getting less pathologizing. However, they've continued to pathologize children who don't need with gender dysphoria rather than just saying it's part of development, which is controversial to some clinicians, including myself. In ICD-11, which has just come out, they have the advantage of not being a mental health categorization only. So there's a new chapter outside mental health, which is very helpful because in some countries, they've used the fact that transgender people have mental health problems to actually put them in mental health institutions and lock them up. So this is a major move, and the ICD is really what most people all over the world should be using. The ICD is owned by the WHO and used by mental health people all over the world. They use the term gender incongruence instead of gender identity disorder. Again, less pathologizing. Unfortunately, they've also continued to use a child diagnosis. Possible psychopathology, and this part is very important. I don't only take a gender history, I also take a general psychiatric history, because many of these young people, because of the issues they've had to face around their gender diversity, have many problems. Younger kids present with somatic problems, headaches or tummy aches in younger kids, and then emotional and behavioral problems. Kids with all sorts of problems, not just transgender, can have these symptoms, but school refusal, for instance, one should be asking, you know, are you being bullied, and have a little index of suspicion. But as they get older, anxiety disorders and depression. And depression is one of the biggest ones, particularly as there's a high risk. 50% will attempt suicide by 18 years old if they don't get the right supports. We have nothing in mental health with that high a suicide attempt level. And that is why I would argue these rather radical protocols of hormones have been put in place, because there is such a poor prognosis if young people don't get the right help. And all of this psychoeducation, as I say, I do tell to parents as well. In terms of who I see people, the youngest I think was 3 years old. There are indeed young kids, if they've got a supportive enough environment, will be very clear from a very young age of who they are. I certainly see every race and every socioeconomic group. I don't make any assumptions. Often people from very wealthy families can be far more worried about transgender than people who come from very modest means or live in townships, where particularly young kids are often more easily accepted, regardless of their gender expression. Whereas, although often it is a major problem once they're in their teenage years. I certainly see people from all faiths, and I do address religion as well. In general, people make assumptions when it comes down to transgender, that because the gays need to be stoned to death, the same applies to the transgender. Whereas in fact, the Bible and most religious teachings don't call for that at all. Transgenders aren't mentioned in the Bible, arguably, at all. And so depending on the family, I will talk to their religion, making it clear that I'm not a spiritual leader, but encouraging them to think about where concerns come from. Because in my experience, all prejudice that I come across either comes from psychiatry or from religion. And while I do my job with facts around psychiatry, it's also important to address religion where you can be helpful. And again, talk about the facts, don't talk about opinions. And if religion is an important part, one can be very helpful. And I'm going to end off there because I think I've run out of time, but I will be coming back to talk more about management.